not only in India, in all over the world. We don't know. We are at the driver's seat, we are also at the passenger seat. Vehicle is available, road is there, and destination, whether we will reach or not, that also only God knows. I mean to say, there is no standard protocol for diabetic management. If today we ask about the management of diabetics, everybody will come forward to manage the diabetic without thinking of what will be the outcome. You go to the GH, go to the medicine ward, go to the nephrology ward, go to cardiology ward, most of the people will be having diabetes for years together, and it will be pathetic to see that all will be having very mutilating ulcers, leg ulcers and other things. Plus they may be landing up with amputations also. And they will proudly tell that they are having diabetes for 15 to 20 years. And they are having the drugs. But why this is? We never ask, they also never ask, because it is going on and we have accepted this as our way of living. And the diabetic patients, they also think, okay, we are having a disease, it's a disease of affluence. Of course, everybody is affected. We are sitting at the top of this volcano where this diabetic has come up to that extent that India is now the capital of diabetes. So that was the first scenario. The video clippings was telling about all this. Nobody knows how to treat, but everybody can treat. So before going again to the details, let me tell you something about, the slides will follow, but let me tell you about the normal insulin response, our body response to insulin release, followed by what happens in type 2 diabetes mellitus. We will be solely concentrating on type 2 diabetes mellitus, not type 1, and what is happening to the insulin release in type 2 diabetes mellitus. Then the newer concept that is recently been added, the incretin and incretin related drugs, or the drugs which help in the functioning of the incretin, its advantages, its disadvantages, and lastly the take home message after the end of this CME. We will be discussing about the normal insulin release in the body to start with. As we know, in normal person, insulin is released in a pulsatile manner, and we have got a rapid phase insulin release followed by ultradian release, and there is diurnal variation. And to your surprise, majority of 50% of the insulin is released in the basal state. Suppose a person will be having around 40 or 60 units of insulin requirement, he will be producing almost 30 units of insulin at the basal state. Rest 50% is pulsatile in nature and also related to the food. That occurs in our normal individuals, those who are euglycemic, no role of diabetes. But in type 2 diabetes mellitus, this pulsatile pattern is lost. Another important thing is the basal insulin secretion in type 2 diabetes mellitus is at the much more higher level. First of all, the insulin pulsatile pattern is lost, and the basal insulin secretion is already at the higher level. So what is happening? Three things happens in type 2 diabetes mellitus. First is, there is insulin resistance. There is body is unable to cope with the glucose because insulin is there, but there is some sort of receptor defect or some mechanisms where the insulin is failing to act.